Without
Dear colleagues, hello.
everything, the guy
It's
is
my
going
pleasure
for
to
that with
present
no.
two methods of dealing with patients with critical limb ischemia. I
It's
have
coming.
no conflict of interest. A small but significant minority of patients with vascular disease have no reasonable target distally, so they're pretty much very difficult to treat. And in those patients, if we don't do anything, the only option for them for relieving the pain is the amputation. Of course, those are very sick patients with a lot of comorbidities. They are diabetes, they are with end-stage renal disease, and very old. For those kind of patients, we kind of seek any solution that could help us save the foot. One of the options in this kind of patients is the venous arterialization, which can fill this need. Actually, the concept of the venous arterialization isn't new. It's very, very old. The first publication is by Hallstedt in a long time ago, last century, but this procedure kind of has a renaissance in the past few years. And actually, it has a very reasonable percentage of limb salvage rate, around 70 to 80%, according to different studies and different trials. There are a few ways to do that. An open surgery, which creates the arterial venous connection surgically, and then surgical disruption of the vein valves. Only percutaneous, when you create the connection percutaneously, and a hybrid method in which you create the bypass surgically, and then you destroy the valves endovascular, or you embolize endovascular the vein collaterals. And the results are not bad. Regarding that, those patients don't have much other options. In the open surgery group, you see the limb salvage rate is around 75%, almost the same percent of limb salvage we see with the total endovascular procedure of venous arterialization, ranging from 60 to 85% in different trials. And of course, there are some dedicated devices like the LymphWall device, which consists of few things, two sheets, and one of the sheets has a side port in which you can puncture the artery from the vein, and in that way to create the connection between the vein and the artery. Because the whole concept of this method is to deliver arterial blood to the vein system in the capillary bed of the critical ischemic limb. And the trial that gives the results from the LymphWall design, the PROMISE-1 trial, now we expect the results from the PROMISE-2 trial maybe next year. But the results from the PROMISE-1 trial are also very good. You see wound healing around, complete wound healing around 75%. And in 90% of patients, we see a partial wound healing, and almost 75% of limb salvage in a very, very long period. And as you can appreciate, the rate of amputation is in the first 19 days, and then it's almost a flat line. So this procedure, it's kind of a very reasonable alternative in patients with critical limb ischemia and no distal target and no revascularization option. I want you to present one case. It's a 73-year-old male with diabetes, with hypertension, with ischemic heart disease, a few coronary interventions. He knows that he had some vasculitis a long time ago. We don't have any documents about that. and he presented with a critical limb ischemia of the foot. This is the angiogram below the knee. As you can see, there are almost nothing left distally. So our strategy was we decided to perform the DVA. We put a wire as distal as we could in the posterior tibial artery, and then inflated a balloon just to gain some lumen. Under an echo, we punctured the posterior tibial vein, inserted the sheath, and through the sheath, we inserted a snare at the level of the tibial artery. Also, antegrately, we inserted another snare in the artery, and percutaneously, we punctured throughout the ears of both snares. And in the soft tissue, we advanced a wire that we captured proximal and distal, I mean, from the vein and from the artery, with the two snares. In that way, we could create a connection between the artery and the vein. After predilation, we implanted a stent graft to secure this, to create the anastomosis. And of course, one of the key things to the procedure is to get a big long balloon and to destroy all the valves in the vein in order to secure antegrade flow throughout the vein. So that was the final result. Actually, the patient had a really nice pain relief, but 6 months later, he returned again with a pain, and we saw that the stent graft and the vein anastomosis was occluded. So we have to do recanalization and balloon dilatation, and that was again the final result. The another key thing, as you can see on the previous slide, those patients have so heavy calcification that, as they say, if he breaks his leg, he can walk on his arteries. So one of the other main issues in critical limb ischemia is dealing with the calcium, which we can find in all arteries throughout the body. Of course, the calcium causes a lot of problems in the procedure. You can have dissections, perforations, embolization. You don't really get a good result after balloon dilatation. You can have a stent crash and stent recoil. And of course, we all know this slide from Fenelli that the more calcium you have, the less absorption of the drug from the DCB you can get. So the DCBs don't do that well when you have that much calcium. So the vessel preparation before we can use either DCB or a balloon is crucial in these heavy calcification arteries. Of course, one of the solution is the intravascular lithotripsy. You know very well the device. It has the shockwave device. It has emitters that transform they have an impulses and they transform the electric energy into kinetic, and they create bubbles that have apply a sonic pressure to the calcium in the media and in the vessel wall, and they have this device actually applies a very high sonic pressure to the wall, and it's really useful, very nice results also from the trials, from the Disrupt 1 and 2 trials. You can see it's a very safe procedure. almost no complications, and the follow-up isn't really bad, almost 80% freedom of clinically driven revascularization. So that's the same guy. He's really poor guy. He returned with a pain in the other leg, not that one with the DVA, but on the other leg, you can appreciate that it's really heavy calcified lesion with a very tight critical stenosis on the common femoral artery, and that he has a very tortuous iliacs and femoral arteries. So we decided to try the shockwave in these settings. We didn't, although surgery is a gold standard in this case, we decided not to perform surgery, but to try with the shockwave. This is the positioning of the shockwave. You can see the emitters here. Actually, in this tortuous, very calcified vessel, we delivered it pretty much easy. The first inflation at 4 atmospheres and the first set of pulses, you can see that there is still not fully expanded. But on the second inflation, it was absolutely fully expanded. We finished classically with the DCB. And that was the final result. I think it was a pretty good result regarding this terrifying vessel. Thank you very much for your attention.